Yeah, ma'am. As at the initial part, I mentioned that one of the ways of accessing it is fluoroscopy guided, but the other way is using sonography or a combination of both. And we have a person who is very passionate about supine PCNL and as well as ultrasound guided puncture. That is Dr. Chandra Mohan Vaddi from Hyderabad. May I request Dr. Chandra Mohan now to take over and share his slides?
Yes, sir. Respected seniors, President Lalit Shah sir, Secretary USI Dr. Uttam sir, and ISU program Dr. Sujata madam and Dr. Arun Chawla sir, thank you for giving the opportunity. I am sharing my screen. That is an excellent presentation by Dr. Gyananda Sharma sir. In fact, he has given the opportunity to me, to be honest. I am fully convinced with the way the Gnana Sharma sir explained. There is no doubt even in a single slide, and everything is absolutely scientific. But my aspect is ultrasound guided puncture and supine PCNL. As you all know, ultrasound is not commonly used in India in PCNL. One of the senior surgeon, very senior surgeon in India, said that I am using for last 30 years, none other than Dr. Mahesh Desai sir, whereas I am using for last 3-4 years ultrasound. Why we don't use and how we have to use either in prone and supine PCNL, I will be focusing on supine PCNL ultrasound. There are two conflicts of interest because most of the ultrasound in these videos are done by BK ultrasound, because that is the one which has attached attachment, and other ultrasounds also have attachments, others have also trajectories, but I am comfortable with BK ultrasound, so those ultrasound videos will be shown. Second conflicts of interest is 50% of the videos are done by Dr. Soundarya and 50% are done, and all the videos are edited by Dr. Soundarya. With this introduction is achieving percutaneous access is the most important step in PCNL. Commonly done under fluoroscopic guidance, as I told, worldwide, not only in India. Cumulative radiation dose for the surgery and recurrent stone formers, we don't give importance because we don't have objective criteria. What will happen, how many urologists got, how many cardiologists got cancer because of usage of CM, it is very difficult to say. So ultrasound, as you know, why it is important is we always say these techniques of BOP or anterior posterior tilting and all this is imagination. Why today 270 audience is present? Because as Uttam sir said, this is bread and butter surgery. Second thing is PCNL CM guided is a semi-blind procedure. Whatever applications you use, sometimes urine will not come. In conferences we see, if urine comes, everybody clap. If urine doesn't come, 1 time, 2 time, 3 times, sometimes senior more surgeons take 10 times also. This type of is because it is semi-blind and you interpret with 0 degree and 30 degree. Exactly needle has to enter. If the system is not dilated, it may not enter. And you are always semi-blind because you are not seeing the structures between the skin and the pelvic calcium system. Only when the kidney moves, you are sure that you are in the kidney. Till that time, where the needle is going, you don't know. You always assume that posterior axillary line, then sitting position posterior axillary line, standing position posterior axillary line. These are all assumptions. And you think that above 10th lung is there, below 10th pleura is there, below, as assumption. To reduce that ultrasound, it can reduce. Now these are the important points. 3-dimensional imaging. No doubt any person who use ultrasound, forget about BK, forget about XYZ. Any ultrasound of 10 to 12 lakhs mission also, if you put on the back, you can easily see the kidney. You can easily see the muscles. You can easily see the rib. These 3 structures, undoubtedly you can see. You can always see how much depth the kidney is. Let it be obese, let it be thin, let it be child. You can see the depth and the direction. Because ultrasound, whenever you put on the kidney, it will see only the eye front part. When you see with your eyes normally, whatever the front person you are seeing, that only ultrasound will see. That means if ultrasound is seeing one calyx, means it is the bull's eye of that calyx. If you change the ultrasound position, that calyx will disappear. If you change, one more calyx will come, that is bull's eye. Whether it is anterior, whether it is posterior, you leave it. Ultrasound probe from the paraspinal region, if you keep on tilting, whether prone or supine, the convex border of the skin, whichever calyx you see in the center, it is the bullseye. Whichever calyx is disappearing, it is going more posterior. Whichever calyx is appearing, it is more anterior. Whichever calyx is appearing more anterior, it is more anterior. After certain time, you don't see anything, you will see the column. That means kidney is over. That means you can clearly see where you do CM guided puncture, but you know where is the calyx, which is the bullseye. After the rest of all the surgery, you do CM. That is the most important use of ultrasound we have to practice. Then this reduces the blindness of the puncture, shortens the tract. See, what is bullseye? You put in CM, it is the shortest tract. In ultrasound is also same, but the advantage in ultrasound when compared to bullseye is, in bullseye CM only one dot you can see, but in ultrasound up to 2 to 3 centimeters you can see the calyx. You can avoid the rib, you can avoid certain directional problems. So it is bullseye with a wide range, so that you can select the needle without viscera. Important. So identification of the posterior calyx is very easy. You put the probe posteriorly, come anteriorly, then do it. I am not saying you puncture entire calyx with ultrasound. See where you are and then start. Absolutely safe. Then like liver, spleen, so nicely seen, so nicely. More you put jelly, even normal ultrasound of what I mean to say, most of the ultrasounds lowest cadre are 10 to 12 lakhs, medium cadre are 20 to 25 lakhs. These are present in the hospitals. You shift it to the room, you see once, you select the point and shift back to the room, normal room. Then you use the CM. Avoids intrarenal vascular injury. Why I am telling is, in supine PCNL, first of all, reaching the renal artery is impossible, because you have to go way beyond the spine to reach the renal artery. It is impossible. Very difficult unless you are too rough. Entire needle goes inside and you are doing front and back movements. In fact, in ultrasound guided, either you reach the calyx or you don't reach it. If you combine with CM, it will become much more scientific. Much more scientific. Radiation exposure, of course, does not. See now here, upper pole is not visualized and stone is in the upper pole. How can you puncture? 90% of the Indians can puncture upper pole in this by imagination. But 10% of the people who cannot puncture will go into the infundibular artery. That causes torrential bleeding. Unless it is a large stone where you hit the stone. Even during dilatation, it creates problem. Here, directly you can see the stone in the ultrasound. Now here, if you see 0 degree and 30 degree, absolutely no problem. It is only 1 degree. Wherever the probe is, that is the degree. Whether it is 10 degree, 20 degree, 30 degree. Now coming to the ultrasound guided, fluoro guided. You see the accuracy here. In fluoro guided, you have gone superior part of the calyx. In ultrasound guided, if you keep in the center and don't move, you will exactly go into the center of the calyx. That is, studies are also there. Now, sir has explained so many things, posterior axial line. If you have a retrorenal colon, in one of the live conference conducted by SK Pal sir, he has given his case. I have taken this patient to the downwards to ultrasound room because I was under fear in the initial part of my ultrasound puncture. It was retrorenal colon because I suspected in the CT. Then I went to ultrasound room, marked where my puncture is safe, and chup chop I have shifted the patient back to the theatre. So what the advantage? I tilted the patient more. I have selected the puncture line. From there directly I went into the pelvic calcium system. Everybody clapped. But the real story is ultrasound. Ultrasound said that this is the area where colon is not present. You can see this video. Again I will play. So much medially I have gone in patient fully tilted. Luckily patient is a thin patient. See the colon. Everywhere colon is present. If you have gone with the normal mechanism, see, this is the only place where colon is not present. So that area is, you can imagine that area was renal angle area, not even below the 12th rib, renal angle area. So certain things you have to see on CT and ultrasound and get into the picture. If you are very intelligent, you can see in both the things. You can clearly see the red part. You can avoid that and you can go into, so that even small arcuate arteries can be avoided. Sometimes we do in CM not straight, a little comfortable position to puncture the calyx. This can be clearly avoided. How to start? See, whenever you take the ultrasound mission, you have to see the probe type, examination type, patient ID, transducer orientation. After that, you have to select frequency, depth, gain and focus. One time if you do this along with radiologist, it is very easy. You write down, it will come easily. This is not a big job. See here, I am keeping the probe type is curvilinear probe. You have to select. Probes, 4 probes will be there. One for ultrasound abdomen, one for the Doppler scrotum, one for the echocardiogram, another is transvaginal probe for the pregnancy in routine ultrasound. You select this. After selecting, you go to the kidney so that superficial and deep in between it will come. Then after that, first you have to practice the probe. In any probe which has an attachment for puncture line, you can put it up or down. So whether you keep it up or down, trajectory will be the same. Only thing is, you have to move the kidney and go to the liver and then identify which direction you are moving. Anterior you go, colon will come. Posterior you go, kidney will disappear. Superior you go, spleen will come. Inferior you go, the kidney will disappear. So if you do like that, center part of the kidney you keep. Mark yourself your area of interest. Second is, as you know, kidney is more posterior superiorly. So if you tilt the probe more superiorly, exactly in the picture in this will come. That means in that position only, entire kidney can be assessed as if you are in the CT. As if you are in the CT. CT scan is too much information. Same information you will get with ultrasound with good quality. Now coming, you see here, when I am orientation of the probe, whenever I am moving up and down, you can clearly see that. Now here orientation of the probe again. The liver is coming. Everybody can see liver in the right side. Everybody can see liver in the left side of the screen. That means depending on the probe which is superior part of the kidney, which is inferior part of the kidney, it is very easy. Absolutely no problem. Now coming to the longitudinal orientation, you see if you tilt subhepatic region, entire kidney length is seen. Similarly, you see how the liver and spleen look like, how the kidney looks like. Liver looks more a little white, you can say, than the kidney. Same spleen little white than the kidney. You can easily identify this surface, the margin between the kidney and the liver. If it is like this, it is very anterior. You will never puncture in this position. But just you will see whether hepatomegaly is present or not. These are, you can never miss any viscera. Now see the colon. Everybody should see this. Colon will be seen as irregular white line. Multiple times you move front and back, you can clearly see hastrations and you can clearly avoid the colon. I am telling you, if you use ultrasound probe for only for 5 minutes, practice, get radiologist, put the probe, see the bowel, go below it, see the liver, go below it and mark one area of 4 centimeters. In that 4 centimeter, whatever the puncture through the C-arm you do, fair enough. And now you see adjacent viscera, diaphragm, pleura. You can see on the left, one small line, pleura is coming. You can clearly see white line, pleura is coming. When the respiration comes, it comes down. How much it will come down, how much it will go, rib, paramedian, median, lateral, who will calculate on the table after draping? You put the ultrasound probe, wherever ask the anesthetist to take deep respiration, the white line of the pleura will come down. You mark, don't go above that. Don't go above that. That's all. Now coming to the rib shadow, this is the only problem. Rib shadow looks like a black shadow obscuring entire kidney. You need experience only for this. I must tell you, the crowded ribs is a nuisance in ultrasound. So if the kidney is subcostal lot of the kidney, ultrasound needs a lot of skill. This is the one problem where you have to acquaint. The answer for this is, in various position, quickly move the probe. Whatever direction you move, in one position, a rib shadow will not come into the picture. Now coming to the steps of the procedure, any needle, ultrasound needle is same. Echo tip needle can come with Cook, but we are using the routine needle. What happens in ultrasound is, skin and 3 muscles will be seen within a nice area of the kidney. No structure should be in between. Your trajectory line should be clearly going through the skin, 1 or 2, 3 muscles and directly kidney. Anybody can identify this with normal ultrasound also. So once you see, you move you move in such a that you have to select the calyx. See, identifying the calyx is simple: posterior or anterior depending on the probe, inferior or superior depending on which you wanted to go. If it is pelvic stone, whichever is directly in front of your ultrasound probe, you go directly, stone will be seen. If it is calyceal stone and pelvic stone, you have to aim the stone. In such case, ultrasound is very, very useful. One small stone is there in the inferior calyx. You keep the probe to that calyx and puncture. Directly first that stone will come out. After that, pelvic stone will come. Puncture technique, techniques and tips to overcome difficulty. See, you have to hold firmly. If you keep on loosely moving, the skin, subcutaneous fat, the respiratory movements, anesthetist movement, everything will come in the way. So you have to firmly hold when you are puncturing. That means as if you are fixing something, the skin and subcutaneous tissue, so that it will not move, especially in obese patient. Always tilt in the direction of the kidney. Total kidney, if you are seeing, you are safe. Total vertical part of the kidney, if you are seeing, then you clearly know which calyx you are going. For short period of time, apnea. One of the case Gnanendra Sharma sir shown, really spinal anesthesia. All of you who are doing under spinal, really great. I do under general anesthesia. Patient takes so much breathing. Sometimes I feel that why I have to take so much pain. Stop it and then go it. But he has shown nicely. Lot of Indian urologists are doing spinal. But you might be knowing that if you stop the respiration for short seconds, then it is easy. Same applies to ultrasound. Infundibulum calyx alignment is directly seeing it. That's all. If you are seeing only pelvis, you will not puncture. Now coming to the skin stretch and hold by assistant. These are all there for contrast. This is elimination rib shadow tactfully. I already told you have to use tactfully. First of all, when do you need ultrasound? Is it necessary? Why you have to learn? Everybody says, you know, Western people does not know C-arm puncture. That's why they are using ultrasound. Please do not place these comments casually. It is absolutely wrong. Nobody is perfect. You cannot say entire India is perfect in C-arm. Entire Western is not at all perfect in C-arm. That is not correct. Ultrasound is the only way to assess the initial puncture site. This is by rule. Whether you use afterwards C-arm or not, it's up to you. Second point is the 4 lines here it has given is mandatory you have to learn. For example, impacted PUJ calculus is there. 1 drop of contrast is not going into the kidney. What will you do? Will you abandon the procedure or will you blindly puncture in 2024 below the 12th rib? Many people can puncture, urine will come. That is not great, but that is not the answer. You have to see with ultrasound. Next, impacted stone in infundibulum. What will you do? Even that blind puncture also you cannot do. Even nobody can help. Then what will you do? C-arm, you put the stone and lateral to stone you will puncture. Is it correct to imagine like that the depth? Not at all correct. Can you directly hit the infundibular stone of the upper calyx? Not at all correct. Infundibular artery of the upper calyx can lead to torrential bleeding. Multiple and large lower ureteric stones. Again, how can you pass all the lower ureteric stone when already hydronephrosis is there? First to do the PCNL and then tackle the lower ureteric stone is important. Then ureteric stricture. If you are doing any post radiotherapy, you could not get access. What will you do? And recently I got a case where ureter is completely cut off after URSL. What will you do? Will you do ureteric reimplantation and then the stone? No, only ultrasound guided. So these conditions, better to know the technique than saying that C-arm is enough. C-arm is fairly good. Should not do fluoro guided puncture in urinoma, infected hydronephrosis, abscess, azotemia, pregnancy. How can you do it? How can you inflate the system more when it's already fully tensed up? And that is the easiest case for the ultrasound. Then why not you take the ultrasound? And retrorenal colon, like I said in the conference, if I have proceeded, I might have gone nicely through the colon. Honestly, ectopic pelvic kidney, how will you assess all this 0 degree, 30 degree? First of all, kidney should be in 30 degree to assess all this 0, 30. If the kidney itself is in its own shape, somewhere kilometers away from the liver and somewhere close to spine or crossing that side, crossed ectopic kidney, horseshoe kidney, and pediatric cases, recurrent stone formers. These are the cases. This slide is very important. This slide you cannot throw away. That's why ultrasound is important. Now I will show 5 case scenarios, 5 to 6, absolute indication and how it is tackled. This is one stone. You are injecting contrast, lower calyx is not at all delineating. What will you do? You directly puncture towards the stone direction. 90% urine comes. If urine doesn't come, what will you do? Get the ultrasound, see nicely dilated system. You can see the dip. I will play it again. Water will anybody will show no problem. But you see the dip. You identify the lower calyx. See, nice dilated like C. See the needle how it is coming. See the dipping of the parenchyma. After that you adjust if you want in CM 1 minute this way or that way. Now you see you see the contrast after injection what happens. See now urine has come. Let the urine come out. It's a system. Now see nicely it has gone through the periphery and then past the guide wire and then rest of the procedure. This happens many times. In RGP, this happens. In fact, we use flexible ureteroscope to inject the contrast sometimes if the ultrasound is not there. Now, this is again impacted PUJ calculus with lower calyceal stone. Retrograde catheter not possible. Contrast cannot be injected. Now, what will you do? You see so much dilatation. You see nicely the stone is seen and you put it. This is the trajectory. If you properly put trajectory, you don't see anything. Just close your eyes and pass the needle. 90% of the times it will go into the kidney. 90% of the times. But you should orient 2-3 times. This is the attachment. If you have this attachment, it is better. Now you inject contrast and proceed. See how nicely it has gone into the lower lateral peripheral calyx. You cannot have that much center of the stone, provided if you are able to see the calyx and puncture. If non-dilated system, it is difficult. Now here see, this is usually dilated system. Anybody can puncture. Even if you close your eyes without CM, without anything, you will do, but you at least see the column in supine PCNL. Go BC, how I am going behind it. But there is a small trick. There was some superior calyx approach. If you go, you can nicely go to the calyx. So for that superior calyx approach, see ultrasound probe when you are moving up and down, all the calyces and dilated calyces are seen nicely. Whichever calyx you want to puncture, you puncture. This is easy case, but impacted stone. Even you might have done blind puncture in this case. I say this is the case. See, upper calyx stone is there and contrast is not going. Radiolucent stone, I have already shown this, but video I have not shown. See, so much dilatation in the upper calyx, so much viscera free space. Now I will go to the trajectory. I will move to the upper calyx. See, trajectory I am moving to the upper calyx. See, in any structure in between, nothing, no liver, no intestine. You directly go and puncture it. For safety purpose, I have taken already lower calyx under CM. Now upper calyx I am taking, because if you see, inject nicely, upper calyx is seen, total upper calyx is seen. Then you dilatation and do that calyx. Because if by chance upper calyx cannot be approached, better to park the guide wire in the beginning only. This is a very interesting case. Upper ureteric stone, somebody has attempted, it caused a urinoma and it is a diverticular stone. All urinoma got infected, multiple stones in the diverticulum are there. You see here, first you have to drain urine. See, so many stones are seen in the diverticulum. Direct you go into the diverticulum. Why unnecessarily imagine? See the needle in the center of the diverticulum. Urine definitely will come. You take for culture, you dilate and take it. After that you can remove the urinoma also. There is absolutely no problem. The entire thing is delineated. Now see, the urinoma is also drained. So urinoma drainage is also very easy. It looks very big. You can directly go into it and put a separate catheter into that. Now this is multiple lower ureteric stones. I already mentioned, if you cannot pass any ureteric catheter or any cannot turn, then that too radiolucent stone in the kidney. See, this is the kidney. Now you carefully see, this is the puncture. It has gone through the infundibulum. You need little experience to assess the infundibulum. This is this, and then after that you see how lateral in supine PCNL sir said that inferior and lower calyces cannot be punctured. It can be punctured through lateral part of the calyx through the ultrasound. See here also nice undilated tip calyx, it has gone. There will be failures. I am not saying, I will show only the successes. I will not show any failures. Now this is the lower ureteric injury with urinoma. This is a disaster. One ureteric stone small was there, somebody attempted and it has urinoma formed and hydronephrosis is there, fever is there. You have to do something. You have to drain urinoma, see the ureter, nothing can be passed in the ureter. It is abruptly cut off. It is abruptly cut off. That means while doing URSL, somebody has perforated and not avulsed, perforated completely through and through. No guide wire goes, no contrast goes. Now see the ultrasound. This is the urinoma, large urinoma. This is the kidney. Now we are puncturing the kidney. Nicely window is there. You can see the spleen and this is punctured and you went inside. You put only PCN. Don't do anything. Now urinoma is drained. This is only PCN, not PCNL. It's only ureteric stone, small ureteric stone. This is the urinoma. Now you put into the urinoma, you take out the needle and same like urine it will come. See, same urine is coming. After that what you do dilatation and then after the dilatation, this is the dilator in the urinoma just below the kidney and you put one monocat catheter. This is the urinoma drainage. And post-op you cannot imagine, complete dry. This is the post-op picture, completely dry, no single drop of urine and nicely kidney is saved. Avulsion of the ureter, urinoma or ureteric injury in gynecological, ultrasound is very, very useful. Otherwise you will unnecessarily cause more problem. This is lower ureteric injury, solitary kidney. So I only has done this case, lower ureteric injury in solitary kidney. So what you have to do, you have to be very careful, give Lasix, IV fluids. Instead of giving contrast, you take, see way below posterior axillary line I am there. Posterior axillary is an imaginary line where ultrasound is reality. In line you will see it. After that you inject contrast and you be comfortable. The creatinine was 8 in this patient. You cannot afford to do any mistake. If you do 5-6 times blind puncture, perinephric hematoma forms, patient will have severe morbidity in solitary kidneys. And this is again retrorenal canal which I mentioned, where you have to have guide. Paraspinal region you can puncture. Lot of us do paraspinal puncture. It's only suspicion. If the CT is not done, gone case. If only IVP is done, very difficult. And see the upper pole system is so close to skin, just matter of 2 centimeter. I know that in this case conference, I am entering into the system. Surprisingly, his contrast was so much filled. I was clearly knowing that I will get the urine in this because I was straight onto it and ultrasound I marked. And while coming out, I ensured that the colon is not injured. And this is the last case where the gas shadow is there in the inferior calyx, so-called emphysematous pyelonephritis grade 1. In these cases, putting ureteric catheter and dilating is not essential. You could clearly see the spleen and identify the marking in the ultrasound. Then middle calyx was approachable in this. Frank pus has come in this case. These are the cases if you inject contrast and try multiple times in C-arm, you will get fever and you will get perinephric abscess also. See frank pus, when you aspirate, frank pus. So just put the PCN and come out. No question of meddling and doing the stone. And patient recovered, now due for, in fact it's due. So this is also a case where PUJ obstruction, parapelvic cyst and the PUJ, you have to puncture the stone. You think that this is very easy case, but parapelvic cyst is there. Huge pelvic cyst is there. And when you inject contrast, you know how it looks like. It is only like only pelvis. You are seeing only pelvis. You will puncture invariably pelvis. Now when you see ultrasound, you will see the calyx. And you will be surprised to see the nephrostogram after the calyx is delineated and punctured. See, this is the stone in the calyx. This is the stone in the calyx. You take time, little dip and see. And once you get this, you inject contrast and see, you will be surprised. See how nicely the calyx is protruding from. You can never distend this calyx with RGP. You can never. When you go, see, when you have gone with flexible scope, it has come from the center of the calyx. Center, not even a drop of blood will come. So what does literature say? Same thing, duration, access, radiation will be less, lesser blood transfusion rate, trial and error method, access, the ideal puncture approach, the ultrasound trial and error is better, and increase the accuracy of the puncture, it is better with ultrasound. Even 20 cases is required for ultrasound guided, 60 cases is required for fluoro guided. Somebody has done this thing. Fluoro guided is always when you are teaching, some people will pick up very fast, some people will be always rotating the needle, it will not puncture the system. Somehow they will miss the calycial system. But in ultrasound, if you get a good ultrasound, that is the only problem. I will tell the hiccups. Advantages, all this already I told. And the issues of concern is hypermobility of the kidney, limited space and slippage of the probe, technical difficulties, visualization of the needle, assessment of overall stone burden and choice of ideal calyx are difficult. They are very important points. Whatever the topic I have been given, I will not tell negatives about it. Only one slide I will tell. So many difficulties are there, but with experience we are overcoming. The biggest problem I am telling is trajectory plus the attachment. If it is not there, doing ultrasound guided puncture is problem. For that you have to spend 40-45 lakhs of money, which is useful for the prostate biopsy, which is useful for other things. So to conclude, ultrasound guided PNL is gaining popularity. Gaining means it's already there. In India it is gaining popularity. Definitive advantage in reducing radiation exposure, that okay. Safe, feasible and efficient access can be. Familiarity with intraoperative renal imaging you should get. Alignment of needle in desired trajectory can be done. If you sit with radiologist, my wife is radiologist, so I can sit any number of hours in her room and assess again and again every patient, and then I also learnt like that. On the same concept based on the next month 10th, with your permission I am announcing already multiple times this flyer you might have seen. We are focusing on only ultrasound. That day you can see how many failures that's why I am keeping a little dilated systems. Let's hope we will succeed. So as you start to walk on the way appears. So if you don't walk towards the way, you will never find the path. So try to learn ultrasound. If not for PCNL, if you go to the ultrasound room, daily 2 cases if you see with the probe, you will be surprised. You can identify the structures well, and you can definitely, if I can do that, you can easily do that. My success rate is around 80%. But definitely I will use CM. I am not saying CM is mandatory, but I will use at least where to puncture, not the posterior axillary, not the rib. Where to puncture, every case we are using ultrasound. So I feel that it is useful and complication rates are less. Thank you very much once again for giving the opportunity.